Hi, my name is Dr. Jason Smithson. I'm a general dentist from a place called Truro in Cornwall in the extreme southwest of England, and today I'd like to present my online lecture, the Class 4 Composite, in two different ways. Before I begin my presentation, I'd just like to make a very brief disclosure. Today's presentation has been sponsored entirely by Cosmodent. However, in the past I've received material and financial compensation by a number of other companies which are listed below. All of the cases are carried out on normal fee-paying patients that have their treatment carried out within normal timeframes. This is just regular everyday dentistry. I don't use any Photoshop other than straightening, cropping and exposure adjustment. So you may on some of the images see an odd defect, you may see a little bit of dust, you may see a tear in the rubber dam, you may see a bit of blood. I make no apologies for that. This is just normal everyday dentistry as is carried out in my normal dental office in Truro in Cornwall. The cases are all my own other than where credited. What we're talking about today really is how we behave as dentists, really like artists, how we use composite resin and our brain and our hands to create restorations that look like natural teeth. I'd just like to show you this case first of all. This is Clan. Clan is a young lady. She's about 25 years of age. She's quite a cool young lady with red hair. She's actually a hairdresser. She's in fact my hairdresser, so she's not a very busy person, as you may be able to see from the image on the screen. One day she was cutting my hair and she said to me, "I don't like my front teeth." And I said to her, "Well, what don't you like about your front teeth?" She said, "Well, I think the front teeth look a little bit big." And actually, if you look at her, it's not the central incisors that look too large, it's the lateral incisors that are too small. The lateral incisors are slightly diminutive. The central incisors are actually beautiful, in my opinion. They have a very nice straight contact point in the midline. The distal is slightly curved. They have this beautiful vertical texture here and here, and they have some pericymata, some growth lines which are apparent often in younger patients. And what makes this case very beautiful is the translucency in the incisal edge. She has this blue opalescence and this orange counter opalescence, and you can see here how the orange cuts through the blue to give this beautiful effect on the incisal edge. So she came along to my office, and our game plan was to do composite resin veneers, class 4 stroke composite resin veneers on the laterals to convert the laterals into better proportioned teeth. So we applied our rubber dam for isolation. We used some floss ties to invert the papillae and also to give us better interproximal isolation and to seal the rubber dam. And we sandblasted the teeth to remove the aprismatic layer of the enamel and give higher bond strengths. We had to do a small amount of preparation on the incisal edge here and here. The reason for that is that the lateral incisors were slightly proclined. This means that we had to do a little bit of enamel preparation just to bring them back into the line of the arch. But as you can see, it's very minimal and it's purely within enamel. And then we layered, and here we got a nice effect with the lateral incisors. So here we've got this lateral incisor, which is right lateral incisor, known in the US as a 7. Much better proportion, better length to width proportion. This other lateral incisor, again, better length to width proportion. Something I like to do is to make the lateral incisors slightly different. We make the central incisors identical, the lateral incisors slightly different. It just gives a little bit more play to the case, a little bit more balance, if you will. Here you can see at the incisal edge, we've duplicated the orange right at the incisal edge and a little bit of blue for the opalescence there, and the polish is very nice. The transition from the natural tooth blends very, very nicely with the restoration margin, which you can just see is here. So, and this is her final smile, much more regular, better proportioned smile. So what are we going to talk about today? Well, firstly, I'd like to talk about the role of translucency, because in my opinion this is critical to the selection of composite resin. Then I'd like to talk about how to do a class 4 using the natural layering approach, a more complex approach, and then the class 4 using a more simple approach, which is probably applicable for the general practitioner in the average practice. So what about translucency? When we think about translucency, we often think about translucency as being an absolute term. We often think of high translucency. But what we often forget is translucency is actually a scale. At one end of the scale, we have high translucence or transparency. However, at the other end of the scale, we have low translucence or opacity. And here you can see this picture. This is an Amazonian tree frog. And this tree frog has very, very translucent skin. And because its skin is very translucent, in fact transparent, you can actually see its internal organs through the skin. But the internal organ here, the lung, is much more opaque. How does this affect us as dentists? Well, as dentists we need to know that a dentine is a very opaque structure, whereas the dento-enamel complex, the interface between the dentine and the enamel, is much more transparent. The dento-enamel complex, or DEC, is totally transparent, a little bit like window glass. The enamel, which goes over the top of the dentine and the dento-enamel complex, is translucent, but it's not quite as translucent as the dentine enamel complex. So in reality, in a tooth, we have three different levels of translucency. We have opaque dentine, we have highly transparent dento-enamel complex, and we have highly translucent enamel. For the everyday average practitioner, really we only need to think in terms of dentine, which is opaque, and enamel, which is highly translucent. So our requirements in general dental practice for dentine and enamel composites are very, very different in terms of translucence. A common error is to attempt to do a class 4 composite resin in one universal shade. Now, when manufacturers make universal composites, what they do is they choose a level of translucency which falls somewhere between the dentine and the enamel, usually about halfway between both. And the outcome is that that universal composite is more translucent than dentine, yet less translucent than enamel. So the outcome for your restoration is that the restoration is more translucent than the surrounding tooth structure. So when the light hits your tooth structure, some of the light is blocked. When the light hits the restoration, less of the light is blocked, so more light travels through the restoration and you see more of the back of the mouth. As a result of that, the restoration will appear grey or low value, which obviously is not optimal for your restoration. Getting deeper into composite resins, for any one given shade of composite resin, let's say for example an A2 microfill will be more translucent than an A2 nano, which in itself is more translucent than an A2 microhybrid. So essentially, a microhybrid is more opaque than a microfill, and a microfill is more translucent than a microhybrid. So in real terms, it's more optimal to replace dentine with microhybrids and enamel with microfills, because in terms of translucence, they behave more like teeth. In addition, we also need to consider the substrate shade. For example, if we're doing a case like the one I've just shown you, Kalan, we would probably consider doing the final facial layer, the final buccal layer, with a microfill. The reason why we choose a microfill for that final buccal layer is for two reasons. Firstly, the light passes through the microfill very, very nicely because it's very, very translucent. So you see the underlying tooth structure, and therefore it's much easier to blend the margins. In addition, the microfill is much more polishable, therefore you get better adaptation at the margins. Conversely, if you had a tooth which was discolored, maybe a brownish or grayish discolored tooth after endodontic treatment, for example, you may consider using both a microhybrid and a microfill on the facial surface. The reason why you'd select the microhybrid on the facial surface is to block light transmission and to get rid of that undesirable discoloration. Then you would put a thin layer of microfill over the top of that to improve the polishability. Let's talk about now the common features of the Class 4 using the natural layering approach and the Class 4 using the simplified approach. When I do a Class 4, I break the Class 4 down into 4 main stages. The first stage is the palatal stent. Now this is usually done prior to the appointment, so I don't consider that really to be part of my workflow. on the actual restoration day. But the three components, preparation, layering and finishing, are all part of the restoration day. Now, most people, when they talk about Class 4, spend a lot of time talking about the layering, but in fact, in my opinion, the layering is one of the least important parts. I spend typically about 50%, about half of the scheduled appointment doing the finishing. About 10 to 20% of the appointment doing the preparation. Pretty much depends on what kind of case you're doing. If you're doing just a fractured tooth, preparation time may be a little bit less. If you're removing an old restoration, maybe some caries, the preparation time may be a bit more. The layering is the remainder of the time. For me, you can do quite average layering, but with good polishing, the restoration will look great. If you do great quality layering and average quality finishing, the restoration always looks poor. So the finishing is the critical part of the appointment, in my opinion. What I'd like to do now is just talk you through a typodont case. So the first part of the typodont case is actually making the palatal stent. The palatal stent can either be made from the existing palatal. The kind of case where you'd use the existing palatal is a little bit like myself. I've just completed a course of orthodontics. I have my upper right central incisor, my 8, has an MID composite resin, and it's getting a bit old and it's a little bit monochromatic, but the shape is ideal and it fits in with my occlusal scheme. So when the dentist who's going to do my restoration goes ahead and places my restoration, all we'll do is we'll make a stent in my mouth from my existing palatal. This is actually quite an unusual situation. In my own practice, usually a patient comes in and has a restoration which is poor in form, so we can't use that, or the tooth is fractured. If the tooth is poor in form or is fractured, we then will consider taking an alginate impression, or in some cases a PVS impression, maybe an opposing model, and in some cases where we're doing multiple units, we may even consider using a face bow and putting the case on an articulator and doing a diagnostic wax up. My own personal preference is not to do intraoral mock-ups. I typically do diagnostic wax ups. Now, when you make the stent is made from PVS putty, just regular impression putty. It should cover the anterior 6 teeth. Now, the reason why it should cover the anterior 6 teeth is to stop the stent from rocking. If you make a stent that only covers 2 or 3 teeth, the stent has the ability to rock either buccally or lingually. If the stent rocks lingually, the incisal edge of your restoration will be too far lingually placed and will be too long. If the stent rocks buccally, the incisal edge of the restoration will be too far buccally placed and will be too short. By covering 6 teeth, what happens is you get a phenomenon called cross-arch bracing. So the stent is very, very stable and the incisal edge ends up in the correct position. Something to consider if you're covering 6 teeth with a stent when you're only restoring 1 tooth is when you place your rubber dam, you must place the rubber dam to encompass 8 teeth rather than 6, otherwise you're going to have problems getting the stent in. The stent should extend interproximally as far as is possible. The reason for that is it reduces the amount of layering you have to do and therefore the amount of polishing. The stent should be sharp and accurate, because if you have folds or air blows in your stent, this means that translates to the negative image in your restoration. The stent should roll over and cover the incisal edge, but should not roll over onto the facial. If the stent rolls over onto the facial, then you're going to have problems with the layering. Many of you, when you make a stent, and I include myself in this, will make a stent that actually rolls over onto the facial. This is not a problem. All you need to do is to trim the stent using this very expensive carpet knife which you get from Home Depot. It's probably about $5. It's a retractable, wide-bladed carpet knife. I prefer this over a scalpel blade. Why? Because you can cut very cleanly and very efficiently with this broader blade. 15 scalpel blade is a little bit more difficult to cut with. You cut in the long axis of the tooth. I'm going to show you this on an image in a moment. And you must maintain the buccal aspect of the incisal edge. So here you look at the stent here. On the stent you can see this is the palatal aspect of the incisal edge, and this is the buccal aspect of the incisal edge, so we retain the buccal aspect of the incisal edge. As you see, this is the tooth we're going to restore. The cut here is parallel to the incisal third of the incisal edge here. This helps your layering. Now, the next problem that we encounter is how much resin to apply to the stent before we put it onto the tooth. Because if we put too much resin into the stent, we end up with massive overhangs, and this creates a lot of finishing problems. We have to do a lot of finishing after placing the restoration. If we apply too little to the stent, we end up with voids, and the restoration is very easily fractured when the stent is removed. So what is the solution? Well, I take this instrument. This is called an IPCL, or interproximal carver long. It's basically a very, very thin, sharp, flexible, flat plastic, and you're able to use this to score the stent material. So you just hold it along the fracture line and run it along the fracture line and create a score on your stent. So as you can see here, there's a small white score on the stent where the IPCL is scored into it. You don't have to cut deeply into it. You just have to put enough pressure to create a fine white line. Now, when you then place your restorative material, you place the restorative material about 2 millimeters apical to that white line, and that will give you enough restorative material to grab onto the tooth and hold onto the tooth without creating so much that you have finishing issues. Then we do our preparation. We prep the tooth, remove any caries, place a bevel here. This is a 2 millimeter infinity bevel from here to here. We do some air abrasion on the tooth using 29 micron alumina to remove the aprismatic enamel. Then we place our rubber dam and isolate the adjacent teeth here and here with Teflon tape. This is just plumber's tape, which you would get from I want to say Home Base, that's the English version, but somewhere like Home Depot in the US. This just stops you getting bonding agent on the adjacent teeth and linking the teeth together. So now I'd like to talk about the strategies for the natural layering approach in terms of layering. So what we do is we take our stent and some composite resin. Using the Cosmodent range, I would suggest you use something like milky white enamel, milky white occlusal, MWO, or incisal light, IL, or incisal medium, microhybrid, and we apply that with either a BBA or an IPCL to the stent. Then we begin to condense that into the stent using this. This is called a multi-purpose instrument, and here you can see the composite is broadly the right shape, but it's quite thick. Now, using this approach, we want to make the palatal shell, which is this, very, very thin. The reason why we want it to be thin is because we want light to be transmitted through it, and this will create our opalescence effects. So the way we thin this shell is to take a brush. This is a number 3 brush from Cosmodent, and we use a modeling resin. This is a filled liquid modeling resin called Brush and Sculpt, and we use a very small amount of this. We've just put a little amount on the edge of the brush, and then wipe the brush with some 2x2 gauze, just so we don't have excess. If you have a large excess of material, it gets very sticky. It also creates a gray appearance because it's quite translucent, so just remove the excess and brush down into the stent and make it as thin as possible. When it's thin enough, you should start to see the stent through the shell. Here you can see there's a little bit purple showing through this shell. Then we take the shell to the tooth, at which point we haven't light cured. So this is not light cured composite at the moment. Here you can see it's beginning to become adapted to the tooth. Now we adapt this shell very intimately to the tooth. We use a number 3 brush and again a modeling resin, the Brush and Sculpt, to adapt very cleanly here. Now, something we're going to do in a moment is to create the contact points using mylar strips. Now, if you have the composite resin contacting the adjacent tooth, you will not be able to get your mylar strip in. So again, I utilize the IPCL, which is a very, very thin instrument, to go between the teeth and just separate the adjacent tooth from the restoration, so I'm able to get my mylar strip into position. Then we can light cure that increment. Once we've light cured, we very carefully remove the stent, and here you can see we've got a very, very thin palatal shell. Now, interproximally, we just use a miler strip. So a regular miler strip you can buy from anywhere. We're not using wedges. Reason why we don't use wedges is because if you introduce a wedge, you've got a very high chance of bleeding, and if you get bleeding at this stage, it makes your life very, very difficult. So now we roll the same shade composite. So for example, if I'd use the milky white occlusal here, I would be using milky white occlusal composite here. We roll it into a ball, and then we use an Ash 6 Explorer and take it to the tooth. Then we condense the material using the multipurpose from Cosmodent. This is a very nice instrument, particularly the thin end of the multipurpose, to condense in this area. Then we use a number 1 brush. Do not use a number 3 brush in this situation, it's much too big. The number 1 brush is much smaller. Again, with a modeling resin, for example, brush and sculpt, and brush downwards, and what we're aiming to do is to adapt the composite resin to the tooth. Then we light cure, and here you can see we've got a palatal shell. Now, there are a couple of issues with this palatal shell. Firstly, it's a little bit thick here, and if I leave it as thick as it is here and here, we'll have a lot of gray in these areas. And also you can see the natural tooth rounds over on this disto-incisal line angle here. This is a little bit uneven, a little bit unwieldy. So what we need to do at this point is to refine. So what I'm doing is I'm just shaping the shell so the shell is the correct shape. The reason I do this before I do the rest of my layering is because if at this point, if I left my shaping right to the end of the procedure and I'd built in all my incisal edge effects, there's quite a high risk of removing those incisal edge effects when you refine the shape of the tooth. If you refine the shape of the shell before you place the incisal edge effects, the incisal edge effects are all in the correct position, and therefore you won't end up removing them at the end. So we're using no water. It's very important not to use water because that will affect your bond strengths. Avoid the tooth structure. Do not touch the tooth with the disc. All we're doing is disking the composite resin here. My preferred disc to do this is the FlexiDisc from Cosmodent. Reason is a lot of products from other companies tend to lose the grit from the disc as you do that, and the grit will go into the restoration and it can look quite unsightly. With the FlexiDisc this doesn't happen. My personal preference is usually to use the blue. Occasionally if the shape is wildly out of form I will use a white and then a blue, but typically I'll just use a blue just to refine the shape. And then in an electric handpiece with a flame diamond, I will use a medium grit flame diamond just to thin out the shell. Obviously that creates a lot of debris, so at the end we just blow away the debris with just the air component of the 3-in-1 syringe. Do not use the water. And then the tiny bits remaining, you can use a number 3 brush and the modeling resin, the brush and sculpt, just to remove any excess there. And then at the end you will have an optimally shaped shell. How thick should it be? Well, it depends on the material you use, but broadly about 0.7 millimeters. Now frankly, I don't have the instruments, the instrumentation, or frankly not even the motivation to measure this. So if you look at these shells, if you can see through them as you can here, 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 and here, they're about the right thickness. If you cannot see through them, then they're too thick and you need to thin them out a little bit more. Now we start to create our incisal halo. Patients who have very bright incisal halos, this is the area around the incisal edge here, you may consider using one of the super bright shades from Cosmodent. These are very bleach white shades. If you use something like incisal light or incisal medium, you may want to consider using milky white occlusal MWO. One little tip, if you actually use milky white occlusal for the shell, you can omit this stage altogether, so it can save you some time. Some people find that a little bit difficult to do. If you find that challenging, you can just use some tints. A lot of people take the brush, just this number 1 brush, with some creative color white. This happens to be white. Or some people have a little bit of amber along the incisal edge, in which case you'd choose the honey yellow, and just paint along the incisal edge. This is technically a little bit more simple. Then you light cure that. Then we begin to replace our dentine. So now we're using the microhybrid, because as you remember from my discussions of translucency, microhybrid is more similar to dentine in terms of translucency. In fact, it's more opaque. So here we're placing the microhybrid towards the incisal edge. It's finishing maybe 1 to 2 millimeters from the incisal edge, depending on what kind of effect you want to create at the incisal edge. And it comes down and finishes at the fracture line. Don't take this over the fracture line. Here you can see it's very simple shape, just 3 lobes for the central incisor. In bigger cases, you may need to augment the microhybrid with some opaquer. Sometimes the microhybrid is not opaque enough, in which case you need to layer over that a little bit of creative color opaque of the appropriate shade. These teeth are an A2 shade, so you'll be choosing an A2 microhybrid, perhaps with some A2 creative color opaquer. As you can see from this incisal view, this is under contoured. Then over the top of that we use a chromatic enamel. So as I just said, this is an A2 shade tooth, so we would choose either an A2 nano or an A2 microfill, and the material goes from the incisal edge here over the enamel margin over into the tooth structure. My personal preference is to use a microfill. Why? It's more polishable, one, so you get a more aesthetic appearance, and secondly, as we discussed right in the beginning, the microfill is more translucent, so you get a better blend of the margin into the tooth structure there. We begin to create our mamelon effects with this instrument here. This is in fact a posterior instrument for a posterior occlusal anatomy called the POCS, Posterior Occlusal Carver Short. But I actually find this quite useful for dividing the chromatic enamel up into 3 lobes. If you just keep 3 lobes here like so, it looks a little bit artificial. So I then take this instrument here, this is an Ash number 6 probe, and break each of the lobes up into little fingers. It looks much more realistic, much more lifelike. So here you can see from the incisal, the chromatic enamel, the microfill in my hands, is at full contour in the middle third of the tooth, but the incisal edge of the tooth, the incisal 2 to 3 millimeters, is actually slightly under contoured. Why is it under contoured? Well, it's because we need to leave some space to create our opalescence effects. These are highly translucent enamel masses, blues, grays, yellows, or ambers. In the Cosmodent range, the most useful shade to use is the occlusal clear, or OC, which is in fact a microhybrid. We apply this, we basically roll it into a sausage shape, and then apply this with the IPCL, and then condense that very aggressively with the multipurpose. Now this is a very important fact to note. When you then adapt that with a brush, we're adapting this with a number 3 brush and the modeling resin, the Brush and Sculpt. A common error is to brush this material down into the body of the tooth. Now this material, the occlusal clear, is very translucent, which translates to grey, which you actually want at the incisal edge. You do not want that in the mid-third of the tooth. So what we will do at this stage is to brush the excess towards the incisal edge and to remove that with an IPCL, so we don't have a grey appearance in the mid-third of the tooth there. This is really an advanced approach, but it may interest some listeners. After we've placed the occlusal clear and light cured, we may consider putting some small white effects. This will be using the liquid creative color white to link the mamelon tips of the dentine to the incisal edge. You can just see that there, and there. This just gives a very, very lifelike aesthetic effect on the incisal edge. That is then light cured. Then over the top of that, just for the incisal 2 to 3 millimeters, we roll some achromatic enamel. This would be in my hands something like incisal light microfill or one of the super bright microfills, and we just apply this using a thumb in one mass. The reason I use only one mass is so that we don't create folds in the material. If you use 2 or 3 masses, you can end up with folds in the material. By applying it with a thumb rather than an instrument, you can put a lot more pressure on the material. As you apply more pressure with the material, you get rid of any voids, any air bubbles in the material, and therefore when you do your polishing, you're not likely to find lots of air voids and air bubbles, which are quite difficult to repair at this stage. So as you can see here, our enamel layering is now complete and the tooth basically has the correct shape. We now have on the surface, as you may recall, all composite resins are oxygen inhibited and as they polymerize, so there is a kind of a sticky layer on the surface. We need to remove that. Why? Because it's a softer surface, it doesn't polish very well. Also, that gummy surface will tend to ruin your instruments. You'll use a lot more discs and rubber points if you don't remove this surface. So at this point we just apply some Oxygon over the top of the restoration and light cure for 60 seconds. This will give you a much harder surface layer which is not sticky. Now we move on to finishing techniques. What we're aiming to do here is to establish tooth length, tooth width, the marginal ridges and the height of contour. So what we do is we mark the tooth that we are not restoring. This is a tooth we're restoring, the upper right. So we mark the line angles here on the tooth that's not been restored and the height of contour, and then we copy that onto the adjacent tooth, the tooth we are restoring. The height of contour is the greatest bulge where the gingival emergence profile meets the facial. Just a little bit of revision there. Now, something I want you to take on board is we use firstly to establish this height of contour the smallest disc. This is 3/8 of an inch disc and we use it on the backhand, so we're going from gingival towards the incisal, and you can see here the disc is actually bending. This is why it's called a flexi disc. As it bends, it creates a rounded appearance, a more organic appearance at the emergence profile. If you use this forehand, you may have two problems. Firstly, it's very easy to lacerate the gingiva, and secondly, you get flat spots, which really doesn't look tooth-like, it looks more man-made. Once we've created the emergence profile with the 3/8 of an inch disc, we then flip over onto the 1/2 inch disc and go into proximally here and here to create our line angles, again with a backhand movement. We're going to talk about the importance of transition line angles now. This is an interesting case. This was Zoe. Zoe was referred to me by a dentist who'd already done this composite resin veneer. Her history was she's a horse rider. She fell from a horse, broke her upper central incisor. The tooth became non-vital. She had an MID fracture, became non-vital. She had an endodontic procedure which was done to a very high standard. The tooth then became discolored. The dentist internally whitened it. It relapsed. He internally whitened it again. It relapsed again. They then elected to do a veneer. She was given the option of ceramic versus composite resin. She selected the composite resin. He did the composite resin veneer and the patient didn't like it. He did it again, the patient didn't like it. He did it again, the patient didn't like it, and then he referred her to me. So she came along complaining of that this tooth here looks too wide, it looks too bulky, and she felt it looks dead looking. Now, to be honest, this tooth is quite heavily discolored, and for most people I think you would agree that this is actually not a bad result. But if you look at it very, very critically, you can see there are some visible margins here. The mesioincisal line angle, the mesioincisal angle here is not similar to this. This is more rounded, this is more square. But the main problems are these. The mesial line angle of the untouched tooth here is dissimilar from this. The mesial line angle comes across and then falls into nothing. As a result of this mesial line angle falling into nothing here, more of the tooth here hits the light and less is in shadow. As a result of that, the tooth looks wider, so the patient is complaining the tooth looks wide and bulky. Why? Because she's not a dentist, she doesn't understand the language of mesial line angles, so all she can see is the fact that it looks bulky, and in reality it's quite a reasonable complaint. The other thing she's noticing is you see the blue here, the opalescence effect here, is not present in the restored tooth here. So therefore, to the patient, it looks dead. So all we did is we used exactly the same products. This happened to be the Super Bright product from Cosmodent. Redid it, changed the line angle. So here's a line angle here, and we put a little bit of blue on the incisal edge here, 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 a little bit of orange here, polished in a correct manner so you cannot see the transition, and the patient was very happy, and that was redone in less than an hour. Let's talk a little bit about texture now. What we're talking about is how to create lobes, pericymata, lamellae and cracks such as this if appropriate, and surface wear if appropriate. So here on my model, I've drawn just with a normal pencil my mesial and distal grooves, which divide the tooth up into 3 lobes: mesial, mid, and distal lobe. How do we develop that? Well, personally, I will tend to use a burr, either a fine diamond or in this case a carbide finishing burr, in a 1 to 5 speed increasing handpiece, very low speed. We tend to rock this in figure of 8 movements so that the groove is sharper cervically and wider incisally. Then we go on to polish. We polish into those grooves using the rubber points. We use the flexi points in horizontal motions, not vertical motions. And then finally we polish using the flexi buff and enamelize polishing paste at progressively high speed with light touch. We're going to show you a video now that runs through the whole Cosmodent system using the discs and the flexi points, and then finally polishing with enamelize with flexi buffs and flexi buff points. So this is the outcome after a very simple kind of 15-minute polishing procedure which you just saw in the video. Let's have a look at a clinical case. This is a case using two masses of composite resin, a dentine mass and an enamel mass, using the natural layering approach. This is our case. The patient had just completed her orthodontic treatment. And as you can see, she has several issues. Firstly, she has wear on the number 8 tooth. We call her in Europe 1-1. She also has wear on both canine teeth there and there, which she doesn't like. She wants a little bit more pointy canine. But the major problem is the failing class 3/class 4 mesoincisal composite resin on the lateral incisor and the diastema which is present on the lateral incisor. So our game plan is to do some composite resins, very simple no prep composite resin on the central incisor, just add a little bit to the length, no prep composite resin on the canine here and here to add to the length, and a little bit of preparation on this lateral to build this tooth out here and just add to the length slightly. So we did a little bit, we removed all the composite resin just with a burr, removed any caries, did some particle abrasion with 29 micron alumina to remove the aprismatic layer. We made a very small 2mm bevel on this lateral incisor. There is no bevel on this central, it's just completely no prep, and we isolated with the rubber dam. Then we edged using 37% phosphoric acid. We edged the dentine for 15 seconds, the enamel for 30 seconds, and then washed with water spray. Now we're creating our shells on the central, and here we're illustrating the lateral incisor shell. You had an option here of using incisal light, incisal medium, or milky white occlusal. In this case I used incisal light. Then we're building up our dentine. As you recall from our discussion of translucency, we're choosing to use a microhybrid because the microhybrid is more opaque. We're choosing the appropriate Vita shade. This happened to be an A2 case, so we're using A2 microhybrid. As you can see, we've just formed some fingers there. We're using a mylar strip just to isolate the adjacent tooth. Now we're looking to recreate this blue effect here, so we're using the grayish occlusal clear at the incisal edge, just so that incisal 1 to 2 millimeters there. Now what I want you also to see is in the natural tooth she has some white hypocalcifications, so we mimic that very subtly using the creative color white just in this area here. It just helps to blend the restoration into the adjacent tooth structure. Then over the top of that we placed our enamel. Again, as you recall from the translucency discussion, we're looking to use a microfilm. Why? It's highly translucent and blends in at the margin. It's highly polishable. We had a choice of incisal light, incisal medium, or the super brights. In this case we chose incisal light. Here we're marking our line angles. I just use a regular HB pencil, a very sharp one, just to mark our line angles, helps in the polishing. Here is our initial polish without rubber dam removal. And then finally at 2 weeks you can see the restorations have integrated. And we have a nice cosmetic result following her orthodontics. Now I'd like to talk a little bit about the class 4 using a much simpler approach. I love this quote from Steve Jobs: "A designer knows when he has achieved perfection, not when there is nothing more to add, but yet when there is nothing left to take away." And this is to some degree the concept of this guy here, Buddy Mopper. And I've taken some of Buddy's approach and modified it slightly, and I'd just like to show you this today. This is a much simpler approach. It's much easier for the general practitioner to produce a similar quality restoration in a shorter time frame, and it's much less technically demanding. The concept is you use far fewer shades. The incisal edge effects are created with the aid of tints rather than the pure transmission of light. What are the advantages? You need far fewer shades in your box. You need the same amount of composite resin, obviously, but you need far fewer shades to achieve that. It saves time. In my own office, if I do a class 4 or composite resin veneer, it takes broadly about half the length of time using this approach as it would to do the natural layering. It's much easier for the operator. It's less stressful. What are the applications? Budget cases. If a patient has a limited budget and you want to do multiple veneers, often you can do multiple veneers using this approach, which they couldn't afford if you were using the natural layering approach. If I do multiple veneers and a patient has no limitations of budget, I will often do the incisors, the central and lateral incisors, using the natural layering because there's slightly better aesthetics. And then I do the canines and the premolars using the simplified bonding. Why? Because often those cases are long in terms of time frame. And after 3 or 4 hours in the chair, the patient's getting tired, I'm getting tired. We do the central and lateral incisors first. And then at the end, we can very rapidly just do the canines and the premolars using the simplified bonding, and we get a great result. We also sometimes use them in the transition phase of full mouth rehab to regain anterior guidance and to increase occlusal vertical dimension, which is not really the topic of today's discussion. So here we've done our prep. We have a palatal chamfer, a facial bevel, and we round off the line angles with a disc. Now, here we've placed our stent. As you recall from a natural layering, we wanted to place our palatal composite using the natural layering as thin as possible with an achromatic enamel such as the milky white occlusal. This is the exact opposite. In this case, what we were looking to do is to create a thicker layer, therefore it's much easier, it's less technically demanding, and to block the light. We don't want light to be transmitted at the incisal edge here. So here we're using the microhybrid, which is chromatic. So these teeth are A2, so we're choosing here an A2 microhybrid. We light cure that, and then we make a decision. Does this block the light enough? Is it gray or not? If it appears to be gray, we then need to consider adding some opaquer. In this case, we would use A2 opaquer from the Creative Color range. If it blocks the light adequately, we don't need to use the Creative Color. If you look from the side, the material is placed in a concave manner. This means that we've got more space to add our next composite resin on our effects. Over the top of that, we then place a chromatic enamel. In this case, we're using Renamel microfill. Why? Because it's highly polishable. The microfill should extend beyond the margin here onto the tooth structure, and it should be smooth. You remember from the natural layering at the incisal here, we had a very irregular, almost rough appearance, so that would refract the light and give a natural effect. Here we want a very smooth composite resin. Why? Because then we can paint on our tints with our number 1 brush. If these were very rough, the tints would run and bleed and it would look horrible. Towards the incisal edge here, for the incisal 2 to 3 millimeters, it needs to be slightly under contoured. It needs to be full contour for the rest of the restoration. Then we paint on our incisal edge effects. We pick up a number 1 brush. I put the number 1 brush into the modeling resin, the brush and sculpt, and then thin it just with a finger. And then we mix our violet and grey 50-50, so 1 part violet to 1 part grey. This is a concept of Corky wool height. And then apply that to the tooth to mimic this blue appearance here. So basically we're painting on the opalescence. You must be very sparing with this. We then light cure that, and then we can create what we call our counter opalescence or halo effect here using either white, Creative Color white, an amber, Creative Color honey yellow, or a combination of both, again with the number 1 brush. You may choose, as in this case here, this tooth has some horizontal white enamel infractions. So here we're using the white creative color and we're just painting that on with the brush. As you can see here, these infractions are a little bit wide. So before we light cure it, we then dry the brush and run the dry brush down the side of these infractions, and this makes them much narrower and more subtle. Then we light cure. Then over the top of that, we place a very thin layer of highly translucent microfill, such as the incisal light or one of the super bright shades. This should just be in the 2 to 3 millimeters of the incisal edge to cover the effects only. And as you can see, the effects are already showing through. And this is the final outcome. As you can see, the integration between the restoration and the denture tooth is very good with very simple protocols. Then I'd like to talk about a clinical case, the peg lateral. So this young lady came in and she had 2 peg laterals here and here, which had been restored with composite resin, now beginning to fail. These teeth, she was unhappy with the general shape, a little bit worn on the incisal edge. She didn't like the discoloration here, and she wanted me to treat these teeth no preparation. So what we did is we just removed the composite resin under magnification. I tend to use a microscope with some gingival retraction cord. You can just see the retraction cord there and there in place. And then we air abraded the teeth to remove any biofilm and aprismatic enamel. Then we layered using the simplified layering approach, and this is the final outcome. All we've used here is a microhybrid on the palatal, a few tints on the incisal edge. You can see the blue, a little bit of orange, a little bit of white, and then over the top of that, this was in fact incisal light, and we've polished. And it's all in the polish. You can see the mesial line angles are identical there, the distal line angles are identical, and we've got some vertical texture which is appropriate for our age group. This is the incisal edge from the side. This is a case which I did fairly recently, just before Christmas. This is a lady with a long-standing patient of mine who had an existing composite resin in her right central incisor, her 8, and this was lost just before Christmas. And she came in to see me, and I looked at her and I said, well, yeah, what we can do is, I'm looking at this tooth and you've got a lot of effects here in the incisal edge. You've got this orange here and a little bit of blue here. So what I'd like to do is to just take some impressions and alginate of your teeth, do a little diagnostic wax up, and then make a putty stent. And then you can come back in a day or two and we can do this restoration. And she kind of looked at me like I was totally crazy. And she said, no, I want this doing now. And I booked her in to say, we have a fairly busy office and we don't have time scheduled for emergencies. So typically if an emergency comes along, I will see them just at the end of my morning session before lunch. I take about 45 minutes for lunch, and just see them for 5-10 minutes, diagnose the problem, take the appropriate radiographs, impressions if necessary, and then schedule them for their appointment at a later date. But she wanted it done now. So after I'd done my initial exam and taken a radiograph of this tooth, I had only 40 minutes left and I had no stent. So I decided to do this then and there, using my finger as a stent and using the simplified layering. Why did I use a simplified layering in this case? Because I didn't have very much time. So here we put our rubber dam on, we've done our air abrasion. You can see the enamel looks slightly chalky here where I've done the air abrasion. We've placed a little bevel, a 2mm bevel at the margin. Then I put a finger behind the tooth and place my microhybrid. Here this tooth is about an A3, so I'm using A3 microhybrid, and as you can see, the microhybrid alone in this case has been enough to block the light transmission. So I'm not going to need to use a creative color opaquer in this case. I've also separated the teeth, so you can see there's a gap right down the middle there. I did that using the IPCL. Then I put a mylar strip between the teeth and start to form my contact point using a chromatic microfill. And as you can see, the microfill in this A3 shade transmits the light very nicely at the margin here, and even in its unpolished state here, it's beginning to become invisible. However, you can see at the incisal edge here, we have this blue effect here, and then we have this orange effect here, and this then gets to the restoration and it's kind of monochromatic. So I wanted to make this look a little bit better here. So what we did is I just used some tints. I actually used a dark brown, which is very unusual to use in the anterior, but here we've painted on dark brown. I've put a little bit of white here and here, and a little bit of a mixture of violet and grey just here to blend the incisal edge. And as you can see, the incisal edge is starting to look chromatically similar in the restoration to that of the adjacent tooth structure. I'm also beginning to gain a contact point. I then put my mylar strip between the teeth and overlay with an achromatic microfill, in this case incisal light here, and also use what we call the pull-through technique. If you're interested in that technique, Corky Wilhite has a very good video on the Cosmodent website of the pull-through technique, just to gain the contact point with my achromatic microfill. Then we polished using the polishing protocol I showed you earlier, and we were finished in 40 minutes. After my polishing, there are some crack lines within the tooth here, here and here, and we just mimic that in the restoration just by using a 15 scalpel blade. I took a 15 scalpel blade and ran down within the restoration just prior to polishing with the FlexiBuff and the Enamelize, and this creates like a surface enamel infraction which just blends the restoration into the adjacent tooth structure. So to conclude, there are three approaches to the Class 4. We can use a natural layering approach, or we can use a more simplified layering approach. We use opaque dentine, the microhybrid, because the microhybrid is less translucent, in other words is more opaque and mimics dentine, and we use more opaque, more translucent enamel, which is more realistically represented by using the microfill, because the microfill is a more translucent material. And the important thing, in my opinion, is to use a vision enhanced, in other words with a microscope or with good quality 4.5 times loop finishing, using the full protocol for finishing. That is the flexi discs, the flexi points, the enamelized paste, and the flexi buffs. Thank you very much for your attention. This is my wife Kate and my two children, Arabella, who's 10 years old, and Henry, who's 8 years old. We have a place in Italy and we go there every year, and we enjoy it very much. Thank you very much for your attention. Bye bye.